in Canada. When I went after he finished his training with Dr. Shokr, everybody was talking very high about him, including his mentor and everybody in the community. Thank you for this excellent presentation.
Thank you.
Now, I think everybody is hungry, right? We should have eaten since 4 hours or so. We usually take lunch by noontime. I don't know what's going on here. But if you're hungry, what is the best thing to do? No, to hear Dr. Hussein Sheashaa. I have the chance to introduce. It's actually my pleasure, and it's an honor to present Dr. Sheashaa for this presentation. It has been a very long journey with Dr. Hussein. I know him since my day one or maybe my day zero in nephrology because he was my direct senior resident. I learned too much from him, and he's actually one of the reasons that I left Egypt and I went to USA because I cannot compete with him. He knows everything about anything. He has very good, relation with everybody. Everybody likes him, loves him. He's a very smiley person, has excellent personality. He's very multitask person that can do many, many things in no time. He is very updated in all kinds of, not only nephrology, but all kinds of medicine. He has very good achievements and accomplishments in clinical and basic research, and clinical medicine and nephrology, and teaching. He is an amazing person. And I will just leave him to present himself and give us an update about nephrology. I think he's the best one who can teach us about the update in nephrology just in a couple minutes. How's that?
هي المشكله دكتور عمرو في المقدمه الشديده ديت الواحد بعدها يبقى ايه يروح خلاص. طبعا بشكر الاستاذ دكتور عمرو الحسيني صديقي واخي العزيز. احنا الدكتور عمرو الواحد يتعلم منه حاجات كتيره جدا. هو اجي بعدي لكن هو عنده عزيمه غير عاديه. فيعني واحنا زي ما قلت في المحاضره الاولانيه احنا بنشرف بيك. احنا we are very proud ان الدكتور عمرو الحسيني واحد مننا ووصل لهذه المكانه العلميه المرموقه، وانا عارف الكومبيتيشن في امريكا عامل ازاي، وانه بدا السلم من اوله. يعني انا قلت له لو دفعوا لي $1,000,000 مش هشتغل ريزيدنت تاني، لكن بعد ما كان مدرس هنا في المنصوره يبدا الكارير، لانه لازم يبداه صح والا هيبقى على كف عفريت هناك ويوصل لقمته، وان شاء الله مسمع وعامل ساوندنج، فده فخر لنا كلنا. بشكرك يا دكتور عمرو. طبعا بشكر كل المنصه الكريمه، دكتوره عزه ضيفتنا، دكتوره غاده، كل الساده الحضور الاساتذه الافاضل. طبعا انا عارف ان الاستومك كول اقوى من العلم، لكن انا اسمحوا لي هطول شويه. البدايه طبعا زي ما بدانا المره الاولانيه بالصور، دي صوره الوحده مع الدكتور ناجي. ما الواحد ما بيشبعش في الكلام عن الدكتور ناجي لانه فعلا الدكتور ناجي كنز، لكن انا حاطط الصوره ديت لان انا اغفلت في المحاضره الاولانيه ان نشكر عماد مجدي. لمستك الفنيه الرائعه النهارده بموضوع الواتساب احييت الميتنج بان بقى في ديسكشن وبالسهل الممتنع، فشكرا يا عماد. الحاجه الثانيه، الدكتور عماد من سنه جاب فكره لدكتوراه الكلى ان احنا الناس عماله تذاكر ومفيش اسسمنت، طب ما نعمل لهم كل اسبوع امتحان. هم صعب يدعوا عليه، لكن كل اسبوع امتحان الريسبكتيف هم بيدرسوا ايه، بس يبقى معلن الاسبوع ده على الشابتر الفلاني، هو بيكوردينيت وبيجيب الاسئله. فانا بحييك تاني وبشكرك قدام الناس كلها. متشكرين يا عماد. دي صورتنا النهارده اهيت، صوره لايف من القاعه. طبعا بنشكر الدكتور طارق الباز ده المحاضره الجميله، والدكتوره ميا حسب الله، كل الناس، كل الضيوف، كل الحضور، لكم كل التحيه والتقدير. It is very difficult task to give presentation about update in anything because literature is expanding every day. There are many articles, and I know if we apply the rules of critical appraisal that we learned from Professor Nahas, we will find a lot of data unnecessary to be read. But if you go to these prestigious journals in nephrology and other medical journals that have publications for nephrology from January 2019. So all data that will be presented within this presentation exclusively published in this year, in the 4 months. So I'm going to highlight these points. To start with, what about the research in nephrology? Are we leader among medical specialties? The situation in nephrology is clear in this figure. Where we are either in this red color and blue color. So are in the bottom. So are lagging. We are lagging nephrology behind all other medical specialties in doing randomized control trial. That is why the guidelines even in nephrology is of modest. And when we find 1A, you will find 1A for not to treat. So it is very difficult. So this is the blue one is kidney research, and the red one is expanded kidney. Expanded kidney means research in dialysis and transplantation. So are lagging. So this is a call to improve our activities in research. For glomerulonephritis, I am going just to present samples because, as I mentioned, a lot of publications. So this is one of the newcomers of calcineurin inhibitors, voclosporin, for management of lupus nephritis. This is phase 2 trial. And this phase trial has this follow-up for 24 weeks, then 48 weeks. And we have placebo versus voclosporin, small dose and large dose, plus steroid and MMF. And the data here, based on this study, the study showed that adding voclosporin to steroid and mycophenolate mofetil increase subjects of complete renal remission in lupus nephritis. Although there are some side effects, some of them are lethal. If you look here, death is high in voclosporin, even in small dose, but we are waiting the evidence that we will have from phase 3 study, and this is Orinia, renal response in active lupus with voclosporin. So we are waiting phase 3 study. It may show positive data or negative data, so we are waiting further research. Another message from vasculitis. Some females are afraid of cyclophosphamide, which is the state of art for management of vasculitis. It is cyclophosphamide and maybe rituximab. What about mycophenolate mofetil? I think this open label randomized control trial included this is 70 here and 70 here. I consider it a good number for ANCA vasculitis. And this randomized controlled study assured that mycophenolate mofetil is not inferior to cyclophosphamide in inducing remission of ANCA-associated vasculitis. However, the time for relapse is short for mycophenolate mofetil. So this study might impact the practice because MMF induction therapy in patients at low risk of relapse, such as those with myeloperoxidase ANCA, may be suitable for alternative to cyclophosphamide who are afraid of cyclophosphamide. So we are waiting further evidence, but today, if we have this type of vasculitis, we can use mycophenolate mofetil for inducing remission. A newcomer for the management of acquired thrombotic thrombocytopenic purpura, based on this study, HERCULES Trial, including this number of patients. So it is double-blind, randomized controlled trial, tested cablasizumab. What is cablasizumab? It is anti-von Willebrand factor humanized bivalent variable domain only immunoglobulin fragment that inhibits interaction between von Willebrand factor, multimer, and the platelets. It simulates the anti-Willebrand activity of Adams 13. So it is given in a dose 10 milligram intravenous bolus, followed by 10 milligram sub-Q for 30 days. And the data are assuring the outcome, either primary and secondary outcome, showed that the use of this drug enhances recovery of thrombocytopenia in patients with acquired thrombotic thrombocytopenic purpura. And this is to the extent that FDA approved Cablivi, this is the name of the brand of cablisizumab, the first nanobody-based medicine for adults with acquired thrombotic thrombocytopenic purpura. What about AKI? I didn't find strong studies in AKI in 2019, but I find this is an organizational level program of intervention. So this is a way to improve healthy care system in treating acute kidney injury. So it is multi-center pragmatic step wedge cluster randomized trial, including this number in the control and intervention. And I think this is the figure that is that carries the message. No change in mortality if we apply this high level of organization, but hospital length of stay is shortened if we improve the healthcare system. And by applying this delivery, we can pick up the cases. So it increases the power of diagnosis, shorten the hospital stay, but up to this moment, we don't know if this will be reflected on mortality because there is no advantage for 30-day mortality. Regarding CKD domains, this is the biggest domain in this presentation because CKD is nephrology. So I am astonished because in March this year, China released their data registry. Professor Mai, we would like to be like China, not like USA. So we have a special supplement in Kidney International, March 2019, and the harvest of this supplement is published in executive summary in the regular issues. So what we learned from China, so we have China Kidney Disease Network. We know that diabetes is the leading cause of chronic kidney disease. Diabetic kidney disease and all other causes of chronic kidney disease are associated with cardiovascular outcome. Coronary heart disease, stroke, heart failure, and the atrial fibrillation. And they just show coronary heart disease. This is male and female. Male is red color and female is yellow one. Both male and females are affected, and both of them suffered from cardiovascular disease. So chronic kidney disease is a cardiovascular disease. And this is, if we look at the mortality, if there is no CKD, no heart failure or diabetes, mortality rate is 0.6. If there is CKD only, it is 1.6. If it's heart failure only, 4. But if we have CKD and heart failure, it is doubled. So this is the beauty of data registry. So if we know the data, we can individualize our management according to our needs. One of the important questions, what about progression of chronic kidney disease? Is it more common in women or more common in men? So this is one of the studies, this cohort study, including this number of patients, males and females, showed that progression is more rapid in men. So progression is more rapid in men. However, in this review, you can find this fantastic figure. This is sexual dimorphism. Chronic kidney disease, stage 3 and 4, is more common in women. So prevalence of chronic kidney disease is higher in females, maybe due to lupus, pregnancy, etc. But progression toward the end stage kidney disease, here the number of patients dialyzed and transplanted are more common in males. So although prevalence of chronic kidney disease is more in females, according to this data registry, and according to United States Renal Data System, where they found in all countries except Taiwan, the progression of CKD is more common in males than females. About adiposity, this is a large cohort including 5.5 million adults, including addressing the relationship between adiposity fat and occurrence of chronic kidney disease. The higher the body mass index, above 25, the higher the adjusted hazard ratio of chronic kidney disease. Again, the higher the waist circumference, above these values, the higher the rate of CKD. So the obesity is associated with increased risk of GFR decline and mortality in individuals with and without CKD. These findings suggest that the worldwide increase in obesity prevalence could lead to future increase in CKD and end-stage kidney disease prevalence. Although I know You cannot find a double-blind randomized control study to address this issue, but all guidelines, 1A is dictated for lifestyle modification to exercise and to reduce calories. For diabetic kidney disease, I know that Professor Magdi Sharqawi tomorrow will highlight the update on diabetes, but I selected some points. This is CARMELINA trial. I like this trial. Why? Because since a few years, I always look at DPP-4 inhibitors by criticism because of cardiovascular problem extrapolated from saxagliptin. This study included large number of patients, 3,000 in each arm, showed that Lihagliptin is not inferior to placebo regarding cardiovascular side effects. So it assured Lihagliptin has no cardiovascular benefits, but doesn't worsen cardiovascular outcome in diabetic kidney disease patients. Even more, it improves microvascular complications, including microalbuminuria, significantly in comparison to placebo. And this is regarding heart failure with Lihagliptin, no difference. I think this study and this Lancet meta-analysis and other studies, it changes the American Diabetes Association guidelines for diabetes management this year to include in the management of diabetic kidney disease, considering GLP-1 receptor agonist and sodium glucose cotransporter 2 inhibitors. Regarding blood pressure, it is one of the pillars of chronic kidney disease. The most important message that always I think about how to measure blood pressure is the method that we follow in the clinic and accurate for estimating the value of hypertension. I suspect because the environment in the office is not physiological for measuring blood pressure. And to apply guidelines, we should know the style of measurements in the guidelines. Do we offer quiet place for a patient to stay in a calm? It is impossible. So it is, this is one of the studies that addressed this issue in a systematic review and meta-analysis, documenting that automated office blood pressure measurement should replace the recording of blood pressure by nurses and physicians in routine clinical practice. How to treat hypertension in chronic kidney disease based on a lot of literature. This review that will be in this issue of May, this is the order of antihypertensive treatment. We'll start with angiotensin converting enzyme inhibitors or angiotensin receptor blocker, followed by either dihydropyridine calcium channel blocker or diuretics, and ending with mineralocorticoid receptor blockers. This was a very compelling and very irritating questions in Dumyat conference, and I shared Professor Ala Sabri his opinion regarding S inhibitor that we should individualize our management approach. I know in Sheffield there was a trend to stop S inhibitors if estimated GFR is below 20 ml per minute, and it was published, but it was a small cohort of patients. Another cohort was published in 2016 in JAMA, showing if you stop, it is better to continue so long as we monitor potassium. And here, this editorial perspectives, as you see from the title, more harm than good. So they advise to continue, because following numerical values of creatinine is not a reflection of injury inside the human being, and to protect the heart. So at the end of the day, it is individualization approach. So long as I am monitoring the side effects, I can go. Regarding your point, Professor Ala, mineralocorticoid receptor blocker, mineralocorticoid receptor blockers have appealing appearance from the pathophysiology for kidney and heart and other organs. Is there a randomized control trial? Yes. This is a double-blind randomized control trial testing spironolactone in chronic kidney disease. And they found the lower the GFR, the higher the incidence of hyperkalemia. So, yes, we need mineralocorticoid receptor blockers, but we need to monitor side effects. If we use, and the wisdom, if we use a small dose, 25 milligram, the risk of hyperkalemia will be low. At the end, to end this point, it's better if we prescribe spironolactone is to monitor potassium. If potassium is okay, we will take the benefit of mineralocorticoid blockers. And the hope will be in the coming generations of mineralocorticoid receptor blockers. Because spironolactone is within the first generation, has side effects because selectivity is modest, the affinity to progesterone and androgen is high, gonadal axis side effects is high, hyperkalemia is high. But if we look at the finerenone, which is the third generation mineralocorticoid receptor blocker, we are waiting the trials because there are many ongoing trials that may prove the value of adding this member. This is one of the most interesting data that I read through this year, which is the link between beta blocker and bone. And we have Professor Amr. I read this editorial, and I read the full article that was published in the Science in 2018 about this issue. Bone has beta-1 adrenergic receptor. So sympathetic stimulation that is common in chronic kidney disease and the use of beta-1 adrenergic receptor stimulants, all these can stimulate the rank and then osteoporosis. So what about if we use beta blocker? The use of beta blocker may be considered as an adjuvant for treating osteoporosis. But if we apply this in chronic kidney disease and hemodialysis, what about the risk of a dynamic bone disease? So we need this trial to be done and conducted in kidney patients. Tolvaptan, this is one of the cornerstones and FDA approved in treating polycystic kidney disease. But one of the major side effects of this drug is polyuria. This is why I was interested to read this article, because they followed the patient for 3 weeks, measuring 24-hour volume, and they found that urine volume is correlated with higher osmolar excretion. So if I want to reduce polyuria, I can advise the patient to stop late eating, because if I eat meat in the evening, this will lead to urea. Urea will increase the side effect and polyuria. Although the regular prescription of tolvaptan, 90 milligram in early morning, and in 5 p.m. 30 milligram, but they found that the patients have polyuria. This is because they eat late or they eat heavy salt. So to reduce polyuria, to reduce sodium chloride salt intake, and to reduce heavy meals in the evening. This is one of the fantastic INSEAD. This is a syndrome. It is a mirror image of nephrogenic diabetes insipidus. So here in the patient, in diabetes insipidus, the patient is polyuric and may suffer from hypernatremic side. Here the patient has a problem to secrete urine and there is tendency for hyponatremia and even convulsion. And it's not related to antidiuretic hormone. It's a defect in G protein, and since a few days they discovered the new coming germline derived again function mutation in G protein. So how to challenge this patient is by giving tolvaptan. If we give tolvaptan, there is no response. In antidiuretic hormone related, you will find response. Here, no response. Statin and the kidney. This is this strong, although it's network meta-analysis, but included 94,000 participants. Yes, statin is a friend for the heart and the cardiovascular system. But if we look at the kidney, what is the kidney? Renal dysfunction is higher in statin-treated patients. So statins, there is no evidence that a statin has nephroprotective effect. Although you may find one article or two addressing the nephroprotective effect of a statin. The second important point from this network meta-analysis, which is more safer for the kidney, atorva or rosuvastatin, this network meta-analysis confirmed superiority of atorvastatin for the kidney. Even we can shift from LDL, HDL, to improving the function of HDL. So this is a new modality for acute myocardial infarction, is to treat patients with apolipoprotein 1. If I give apolipoprotein 1 for these patients with myocardial infarction with renal impairment, in this dose, this will improve HDL function and improves efflux of the cholesterol, and this is beneficial. This is MAS2 trial. This is post hoc analysis, 14 years. And the key message is we shouldn't deprive chronic kidney disease patients from coronary intervention when it's indicated, because there is inertia from cardiology to intervene with chronic kidney disease patients. Because this study showed that medical treatments are associated with mortality if we leave them on medical treatment while they can be treated. In just a glance, how to treat heart failure in the presence of kidney disease. What is the evidence-based medicine? It is clearly demonstrated in this release of circulation. So we have stages 1 and 2, 3 and 4 and 5. And if you look, the best evidence is toward the use of beta blocker. So beta blocker all through different stages of heart failure works well, followed by ACE inhibitor and ARB and the coming ARNI. Then digoxin and nitrates has no role in managing heart failure in chronic kidney disease. The same diuretics doesn't improve the long-term outcome. I enjoyed the two presentations of Professor Ala in the DNG and in the conference, in the ESNT conference, about metabolic acidosis. And today, Professor Al-Qawsi with his update about one concept, which is progression of chronic kidney disease. This is one of the most recent review. And in this review, they concentrated on a concept to respect metabolic, even subclinical metabolic acidosis. How to pick subclinical metabolic acidosis is by looking at serum bicarbonate. It is 22. It is low normal. So it is normal. But in excess of ammonia secretion. So the kidney keeps bicarb within normal because of compensation. Excess ammonia secretion and generation by kidney generates fibrosis and inflammation. So if we think of that, we can measure ammonia in urine. It is difficult, it's not available everywhere. We can even look at urine anion gap. If it is negative, this means that there is excess ammonium, so it's better to encourage fruits and vegetables, limit sodium chloride, or even giving bicarbonate. This is a drug that Professor Al-Qawsi just mentioned, and this is the phase 3 study. It is released, 12-week follow-up for Vivrimir, fantastic drug, because it binds HCl within the stomach without exchange of salt. So there is no exchange cation. It just absorbs HCl like phosphate binder, so it is HCl binder. But there is the most common side effect is diarrhea, and we are waiting the long-term evaluation of this study to know it will be translated into regression of CKD or not. So, and the editorial commented on this article saying that this is evolution of binders. So the starting was phosphate binders, then potassium binders, resins, and today acid binder, maybe in the future uremia binders. So we are waiting the innovation and the advancement. For dialysis, I selected this article. This is a very nice article that we discussed with Professor Ahmed Abu Wahab. This is the use of sodium bicarbonate catheter lock. Instead of thinking of very expensive locks, we can use isotonic bicarb instead of saline to wash catheters, because bicarbonate reduces bacteria and reduces thrombogenesis of the catheters and keep the catheter well. Spironolactone again in dialysis. These are two randomized controlled trial published this month in the Kidney International. Although they didn't address the efficacy, but they confirmed tolerability if the dose is limited to 25 milligram. Regarding renal transplantation, one of interesting issue is, can we measure the response of rejection by biomarkers? Although biomarkers are expanding, but the acceptance in clinical application is still limited. But it's very nice when I read this in brief article. This is donor-derived cell-free DNA. So during rejection, the kidney is injured. The kidney comes from donor. So this will be associated with increasing the release of DNA from this kidney. So it is donor DNA. And if we treat rejection, here they followed DNA, circulating free DNA. They found if the treatment is effective, the level of circulating free DNA dropped below 1%. So how to apply this? We need to be replicated, but if it is confirmed, if we treat rejection and creatinine doesn't improve, it's not necessarily to continue on severe immune suppressive drugs. Vitamin K, 2K or not 2K, and Professor Ala Sabri. This is a very interesting study. They measured for this number of patients vitamin D and vitamin K, and they measured uncarboxylated matrix glyprotein for vitamin K function, and they measured vitamin D, and they found that if the recipient has poor vitamin D and poor vitamin K, the graft survival is drastically affected. The most interesting is they selected 45 patients with poor vitamin D and vitamin K, and they treated them by 1-alpha. What happened? The mortality increased by 1-alpha. Why? Why vitamin D is associated with increased mortality in this study? They explained the results by vitamin D has promoter activity on matrix glyprotein. So vitamin D, if I treat by vitamin D, I will increase matrix glyprotein. If vitamin K is insufficient, what will happen? The matrix glyprotein will be uncarboxylated, and this will increase vascular stiffness at least and mortality. So are waiting the evidence. To reach the last 2 minutes, regarding the use of, it is better to use solid outcome, like renal failure, like mortality. But what about the change in albuminuria? Does a change in albuminuria translate into effect? This is the 41 randomized controlled trial, including a very large number of patients, showed that, yes, surrogate mark albuminuria works well, especially if it's above 30 milligram per gram as baseline, and drop in albuminuria is above 30%. And you can find the details of this issue. Nowadays, we have MERS. What is MERS? All of us are aware by MACE, major adverse cardiovascular events. And we try to be cardiologists, we try to be diabetologists, so it's better to include a kidney outcome with cardiac outcome in MERS. This is organoids. It seems that the enhancing basic research can solve problems, many problems. I'm not going to tell it in details. I think the most evidence-based medicine nowadays, agreed by all guidelines, is to change lifestyle. And this is from Mando, and Ahmed Rafat is there. This is one of very interesting article that was released a few days in Lancet, showing the effect of diets. So low salt, high salt, high protein, all these are bad. Low fruits and vegetables, bad. Poor carbohydrate, bad. But the problem, as Professor Kosi mentioned, how to be adherent for the diet, this is quite a problem. In nephrology, it's better to enhance fruits and vegetables from early beginning, before they're afraid of hyperkalemia. And we can know that the patient is compliant with fruits and vegetables by measuring urinary potassium. So the higher the urinary potassium, the lower the rate of progression of CKD. And this is why you'll find the kidney here in vegetables, fruits and vegetables. Exercise is essential. Avoiding smoking. Smoking is bad. Smoking is kidney poison. I like this article because it doesn't address smoking, but address second-hand smoking or passive smoking. Passive smoking is associated with progression of kidney disease. Again, medicine is evaluated. It was in the past doctor-centered, then disease-centered, and we'll live the era of patient-centered approach. And currently, since 2015, there is growing a change from patient-centeredness into personal-centered, including doctors, healthcare providers, family, and the patient. So we need a healthy community. This is why education is important, and we established this site of Virtual Academy that was founded by Professor Tariq El-Baz in 2012, and continued with Professor Gamal and Professor Han Hafiz, and I'm sure that Professor Maya Hasaballah will keep it, because it is a very valuable resources for presentations and videos. To end with, as doctors, we should continue student forever. Why? because a doctor is a student till his death. When he fails to be a student, he dies. Or a doctor is a student until he dies. Once he considers himself not a student anymore, بقى باشا خلاص كبير, the doctor inside him dies. أشكركم على حسن الاستماع. هم ماتوا من